Yes, there's a huge gender disparity that's going on, and in speaking with some of the individuals that are kind of there, they basically feel that if a woman is promoted into a higher level, and this is specifically in McKaylee, specifically in the Tigrian region is all I'm speaking to, if you promote a woman into a higher position or a higher level job, you're creating more burden for her because she already has so much burden that's already expected of her at home. And so they're doing her a favor by not including her into the educational program. And when I heard that, I just was like, oh.
But in Liberia, it's 50-50 for OBGYN right now.
Yeah. So it's really, it does. I know it does, but in Ethiopia, they definitely have a problem with it.
Yeah. I mean, the OBGYN department has right now, I think, 10 faculty, and I think only 1 or 2 women. And in the residency program, they only have like 1 per year or something. Kind of like how it used to be here many years ago. And from what I heard, a lot of the female resident medical students, because right now they have 50-50 medical students, women and men, so that's, at least that part is good. And they usually go, I was told, in a non-surgical field, like pediatrics or internal medicine. And when I talked to the few women who are in OBGYN, they say, or who were considering OBGYN but decided against it, they said it was because the surgical fields are much more demanding during residency, and by that time, most of them want to start having families, you know? I mean, I think in the US we've moved to, we're okay suspending having children until we're done with our training. But in Ethiopia, when you are like 25 and you still don't have kids, that's kind of, you get pressured a lot socially. And so I think there's still this mindset that you need to have your children when you're younger, and it just doesn't, there's definitely more days that they're on call in the hospital doing surgeries and things. You know, the OBGYN residency is definitely more intense than a pediatric one. And you have to be in the hospital at night, which most of the internal medicine and pediatric ones, I don't think that you necessarily have to be in the hospital all night long. A lot of times they can call from off-site as long as they live nearby and that kind of stuff. And so I think for whatever reason it was, that was the same problem in this country, is kind of, we are kind of 50 years behind there, right? So I'm optimistic it will change, but.
So the programming for this coming June is including Women in Medicine half-day program, and that's one of our, we're not giving up. We really want to try to highlight what the women are doing in order to demonstrate that they are there and engaging. That the current dean of the medical school's wife is a general surgeon, and Rahel just learned this on the last trip because she begged him to bring his wife, because we've been going there for almost 10 years, and the wife's never come to the end of the trip dinner that is the honor of everyone. It's like we've never met anyone's significant other in any one of the social things that we've all been involved in. So there's lots of cultural barriers to it that I think we just need to keep asking questions in order to kind of keep kind of putting before them that we value this and that they should too. So it's definitely something that we're working on.
Do you find you're treated differently?
No, that's so funny. We talked about that at lunch too today. I don't ever feel like I mean, I'm not treated differently, and I'm a physical therapist on top of not even being a physician. And I walk in the door as a woman with a doctoral degree, and they just treat you with the utmost respect, and they have such respect for you. And so it does surprise me, but it's almost like, well, it's okay for you, but it's not okay for us.
Because you're North American.
Yeah, we have one female vestibular surgeon in the Hamlin centers. She's not, she had a complicated pregnancy and was out for a bit. I'm hoping she comes back, and I don't know if she'll ever be interested in the fellowship or not. I don't know if you heard about her lately. but predominantly men in that system. But I've never had any issues
Yeah.
teaching them as a female to male instructor.
Yeah.
Very
But-
respectful.
But there's, for example, for physical therapy, there's one position that comes out of the academic, people that have been slated for academia, that goes into the program every year, and one position, and these are all the people that work for the center, that is just a clinician. And the clinician position is always given to a male instead of the women that are working as clinicians, or the bachelor's trained clinicians that are there. And that has happened since I started there. And I always keep asking, when is Sega? Because Sega keeps saying that she wants to be in the master's program, which is in the clinician side, and they're not giving her permission to come through.
I wanted to bring up, there's also a group called Women in Global Health, if anybody's run across them on social media, really working towards ending this gender parity. I guess they started about a year or a year and a half ago. So they've got some really interesting resources, and have really been able to partner with WHO, because this year they just came out with a statement. WHO just came out with a statement on gender parity in the health workforce and leadership. How 70% of the workforce across the globe is women, but less than 30% are in leadership positions. So it's going to be hopefully a bigger issue as we move forward.
But I did want to thank the one man who braved today's
Yeah.
I'm
showing all the women.
breaking some rule.
Yeah, I mean, I think being aware of it, and I think our program is just looking into integrating women in global health, like women in healthcare format as part of our fellowship week-long didactic. So that would hopefully bring more conversation with our partners. But I feel like sometimes they don't even recognize it's a problem because it's been part of the culture for so long. So we need to bring it up because we can see it more than they can.
It's so interesting because in some parts of the world, almost every OBGYN is a woman, depending on the cultural acceptability of it. And then yet in other parts, it's too hard to be a woman in that field. So it just really depends.
Yeah. And I really do think that as a culture of how people are educated too, like in the residency programs in Ethiopia right now for OBGYN, it's kind of brutal. I've heard a lot of horror stories about, faculty members yelling at people or, not wanting to come in to help them in the middle of the night with surgeries. I mean, there's a lot of things you hear about the culture of education in surgical programs. And I think as we change that culture, when we go there to teach residents and students, they actually notice how we communicate to people like human beings and how we walk them through and how we want to be there whenever there's something happening. We don't just let them go and do it on their own. And they notice these things. And I've heard a lot of comments about that, how much they're learning from seeing how we do it. So the more we role model these things, the more these training programs become approachable, and I think less likely for women to feel intimidated or not wanting to be in that setting. So I'm optimistic that with that kind of cultural change, if we're working with our partners in that way, that things will get better. As the reputation improves, somehow education is happening too.
Yeah, we found that training residents in Peru, we brought them with us to the mountains to do conservative management. And I suggested that they bring the cases back and to their academic half day or whatever, if they had one, and talk about it. And they're like, you don't understand, like this is so different for us. The academics involve rounds, and one resident's on the hot spot about patient management, and it's all about shame.
It is, and
punishment, and it's nothing positive.
Yeah, and I think that's not conducive to a lot of women wanting to be in that hot seat,
Any person being.
or any person. But I feel like it's even harder on the women experience because all those faculty members are men and most of the people there are men, and so it's not, it needs to change.
Yeah, I've thought this many times when I've observed in the hospital that it's really a bad idea to export our bad habits. And how we train should be analyzed at the level of what would be the ideal environment for learning instead of how you were trained. And really taking a solid look at, they already have disparities in these environments and they already have low resources, and then on top of it, you're shaming them. And it's just really a tough thing to see. So it's like really encouraging people to take a really solid look at what are good learning environments for the betterment of people. That's the reason why you're there even trying to teach. So yeah, it's hard for me to watch.
I remember my fellow, I always used to feel guilty having to bring my own residents and fellows to these things because as part of my role at my institution, I have to do that, which is a good thing for our fellows and our residents, but there's so much need for teaching their residents and their fellows. So we always have to balance it. And so I would do a case with my Ethiopian fellow and the American resident, for example, and I would have my resident do a vaginal hysterectomy, and then I would have my Ethiopian fellow do the suspension, but he has to assist her during her vaginal hysterectomy. So he was noticing the whole time, and here I am feeling really guilty that I'm not giving this case to the Ethiopian resident, and I'm not letting the fellow do the whole thing, when I got back home, and I remember, I got an email from him 2 weeks later or 3 weeks later, and he told me that one of the biggest things he learned from that experience was how to teach the resident, how to talk to her. He was I was so impressed that you were talking to her like a friend, that you didn't take over the case when she wasn't doing it right, and essentially he was actually noticing the communication and the way we were doing it, even though it was taking longer, the patience it takes to teach somebody. And so he said, I started teaching residents like that because they come and rotate with him. He never was taught that way. He literally just took the case away. He wouldn't communicate that way. And he wasn't even aware of it, And he said, I started talking to them like you do. And doing, walking them through the cases, and also minimizing bleeding, making sure that we do it in a minimal blood loss kind of thing. And he said suddenly all these residents from the medical school want to rotate with me now. It's actually the place to be for these residents to come because they're learning a great way to do a hysterectomy. They're not losing 1,000 cc's of blood with a hysterectomy anymore because he's teaching them how to do it properly, but he's talking to them like a human being. And I was really surprised by that because I was feeling guilty that I didn't actually let him do the whole case, but he actually learned a lot more and was able to help other residents so much better.
You could sure tell the
because of
difference
that.
in the fellows from when we started the program and now that they've graduated, and the way they interact with their residents, because they all have residents with them all the time. And they've told me the same thing, when you guys come and you teach us different than we were taught, and now we're teaching our residents that way. And I think that's tremendous, and I think that I love watching them now. I just step back and they do the whole hysterectomy, then they don't really need us for that portion anymore. But that they verbalize it, and I watch the residents who are brand new, who are just they're terrified. They're just terrified when they get there for their very first day. But then once they've worked with our fellows and our visiting professors, they kind of relax and they start having a little fun in learning, I think. So it's little drops of in the bucket, but it's working. I think it's helping.
Yeah, and I'm optimistic when they hear about this that more interest from women will come. And also, more people would be interested in doing the fellowship and things like that.
Every resident that comes through, he's I'm thinking it might be fun. They all give it a lot of thought, but they all have also all of their obligations after training that kind of pull them back so that they can't go into a fellowship right away.
Yeah.
But they all have a lot of interest.
Is there a house service requirement?
Yeah.
So usually that happens after, so they, after medical school, they
Mhm.
practice for 1 year as a resident.
Mhm.
Kind of, they call them 1 year of internship where they rotate with different specialties. And then they have to go and serve in rural communities
service.
for like 3 years before they come back
3
as
years.
residents.
Ah, okay.
So they're also different kind of residents. I mean, they're not the typical resident, you know, in the US
They
where,
have 3 years of life experience
They-
under their belt.
yeah, and sometimes they're very set in their ways because they've been managing things on their
All
own.
on their own, yeah.
Yeah. So your teaching model has like, it's like teaching much more established adults who have been
Mhm.
taking care of things on their own, so it's a little bit different. All right.